one of the most important hormones in your body that almost very few people understand, and that's natural progesterone. There's so many details you need to know. It has such an impact on your health in so many ways: bone density, uh, addressing the issue of estrogen dominance. Almost everyone is exposed to, and that includes us, the guys. And it's not because we uh, have extra estrogen necessarily, but we have estrogen receptor activation from the enormous exposure we have to plastics and microplastics. We're deluged with these. Billions of tons have been produced. Billions of tons, and billions of more tons are on the way. We make that's a lot of plastics, and we've been making it for a long time. And they impact your body by causing estrogen dominance. So one of the ways that you can do that is certainly avoid that, and but that's becoming almost impossible to do nowadays. I mean, it's in almost every tissue in your body. So the reason why plastics harm you is because they activate the estrogen receptors. They're estrogen mimetics. They're mimics. And that's the primary way they harm your biology. And it's a similar, almost identical mechanism of action of PUFA, or linoleic acid. They cause pretty similar problems, except there's no oxidative metabolites like it is with the PUFAs. So, but it just activates those estrogen receptors, and it can radically increase your risk of not only breast cancer, but almost all cancers. So you want to make sure you have the issue, your progesterone is a resource you want to just know about. If not for yourself, then for someone you love and care about, because it's going to be a resource that almost each and every one of you are going to benefit from. And I believe that almost every adult should seriously consider it, because even if you're super healthy, because we live in the 21st century, and the 21st century is loaded with this toxic soup of poisons that is almost impossible to avoid. So I hope you enjoy this interview with Carol Petersen as much as I did discussing it with her.
In the last 30 years, we've learned a lot more about this estrogen burden. We've learned so many things that contribute to too much estrogen effect. And it's not simply your own hormones. The difference between your estrogen effect and your progesterone effect becomes miles apart. And you are having a lot of symptoms. You're anxious, you can't sleep, you get headaches, you go into rages. It can be a little more complex than you would think, but it's entirely learnable. And I think people in general are learning this faster than their medical providers. And the trouble is they're getting very little help from their providers. The good thing is people are starting to take charge of themselves.
Welcome, everyone. Dr. Mercola, helping you take control of your health. And today we're joined by Carol Petersen, who has been a pharmacist for a while. And she worked, many of you may know her from her role that she played in Women's International Pharmacy for many years. She was the head pharmacist there, and they were probably, you can describe them better, but they were clearly one of the premier compounding pharmacists in the United States. And then things happened with COVID, so that changed her life quite a bit. And then she pivoted, and she's now a health coach and helping serving people, especially about a topic that is near and dear to my heart and hers. And she actually has significantly superior knowledge to me in this area, and that's very uncommon. And because and that's about bioidentical hormone replacement therapy. And I'll tell you, it's a challenge. I love this dearly, and I try to get people to interview, but every one of them I disagree with. Carol is one of the few people who I agree with. Why? Because we share the same mentors, and that would be Ray Peat and his mentor, which is Katarina Dalton. So, and if you want to know, and I don't think most of her written work is really available. It's really obscure, hard to find. But Carol has been studying her work in this field for a long time, and I really don't know personally anyone better than her with more expertise. And you're going to have to save this one for the records, because you're going to want to go back and listen to it continuously, because there's going to be so much great information in here that's going to help you. And we're going to dispel a lot of the myths, the crazy myths that people even think they should test for estrogen in your blood or serum or urine. It's ridiculous. It's nonsense. You're wasting your money. You're going to get misinformation, bad information. It's worse than not testing at all because they're not going to tell you what's going on in reality in your body. And we'll tell you exactly why that is in a moment. And a better alternative that costs a fraction of the price. All right. So with all that introduction, welcome and thank you for joining us today, Carol.
Thank you so much. It's my pleasure, Dr. Mercola. You're quite right. I started being a pharmacist in 1972. So,
ooh, baby, that's a while ago. Yeah. Now, back
and
then, actually, it's interesting. At that year, I was a pharmacy apprentice.
wow, that's very
Licensed pharmacy
interesting.
apprentice in the state of Illinois. And at that time, you did not need a PhD to graduate pharmacy school. That probably was that this century or last century that happened?
Very, very interesting. My preceptor for my pharmacy degree, we had to put a year in at that point. My preceptor for half of that had gone to Marquette University and did a 6-month program. And thereafter, he was a pharmacist. So
wow, that much training, not much training. It's quite a bit different today. It's maybe you can touch on that to just let people, because not many people know about that transition. You were there, but in the old days, and it's quite different now.
It is quite different. There were a lot fewer drugs, actually, as you might imagine, since they load us up with so many drugs, and a lot more opportunity for the pharmacists back then. I think we've been isolating pharmacists from people for a long time. I was thinking one day, it's one medical profession where we never touch patients. And I thought that was kind of strange. I started hugging people when they came and asked questions, and it was good for me, and I think it was good for them. We're so remote now. Physicians are remote to their patients. Pharmacists are remote. Nurse practitioners are remote. We've taken the soul out of medicine, and we've turned it into a flowchart. I wrote a blog on flowchart tyranny. Medical profession, they really wanted to shrink it into a yes, no, this or that. And that's a big problem. Human beings aren't binary like that. They're complex individuals and have different life stories. And that's what makes working with hormones a little challenging. Conventional doctors find it too complex to think about, yet it's simple. And it's got a scientific basis that the drugs don't have. You introduce a foreign substance into the body, you don't know what it's going to do, where it's going to do, how it's going to do, how fast you eliminate it, if you can eliminate it. It's
it's crazy.
It's just plain crazy. Thank you for
yes, indeed. Yeah, it's not surprising. It's actually quite predictable too. So, but that's what we're here for. We hope to help and enable and provide people with the knowledge that they require to navigate through these pathways. And before we start engaging in this, with most people, it's a really complex situation, but we're going to simplify it for you. But I also want to emphasize that these hormone supplementations are rarely ever the magic bullet. They're done in conjunction with lifestyle modification, addressing the causes, because your hormones are usually out of range, out of whack, not balanced because of things that you're doing. And if you think they're a magic bullet like a drug that's going to turn your life around, you're confused. Now, they will help quite a bit, especially with progesterone, which we're going to talk about in great detail. But still, you want to address the reasons why you need that augmentation. And for many of us, it's going to be we'll need it the rest of our lives. We just will. That's just the inevitable reality because we've been exposed to stuff that really poisoned us throughout the years, the decades. And not because we were foolish or stupid, but because we were brainwashed and propagandized by large corporate interests whose our best interest was not theirs. They were in it for the money, exclusively, no other reason. And that's the primary motivation for many of the reasons why people are failing in health. So anyway, I also want to mention that you, as I mentioned earlier, you're a health coach, and I think what is it, $300 an hour you charge for your after your $15 consultation? Yeah,
$220.
$220. Okay, $220
for a longer coaching. And it really depends on how you come to me, because many women have done a lot of research. They've looked at my videos. They've looked at your videos. They come and they are very well informed about hormones and
Yes.
health in general. They don't need much. They come to
Right.
me for an hour. They want to fine tune what they're doing, ask some questions.
That's what I wanted. I want to identify the purpose of this video is to give you the primer foundational information that many of you will be able to do it yourself. This isn't, but Carol there's there for a resource. If you need some fine tuning, she's going to be available. And if you watch and study what we're going to share here now, you're almost home and you just might need a little fine tuning, and Carol can help you with that. So this is not a pitch to. Carol's busy for a long time. This is really the intention of this video is to empower you, to give you the knowledge so that you can do it yourself. We're not here to give you fish. We're here to teach you how to fish. That's the purpose. That's what I've been doing for over a quarter century on this website. So with that preface, I think we should start to dive in because it's a lot to talk about. But again, Ray Pete has been our mentor, and I started following him aggressively not even 2 years ago. I knew of his work for over 3 decades, and I ignored it because I thought he was a wacko and it was crazy. I mean, it was, how could carbohydrates be good for you? They're obviously villainous, But 2 years ago, I woke up and it took me 18 months to study his work and finally understand it. And then a few more months before I actually advanced his work. I think one of the few people to do that in some really important areas in the microbiome and how carbohydrates impact the microbiome. So it's a refinement. It's not a replacement. It's just a refinement of his groundbreaking, pioneering work. Magnificent man. And we're sad that he left 2 years ago. But you found him a lot before I did. Well, we found him probably at the same time, but you listened to him and I didn't. I chose to ignore him. And you embraced him. And as a result, you're decades ahead of me. So why don't you share your journey?
So I started working for Women's International Pharmacy. And we were basing our therapy on Katarina Dalton's work. And she pioneered and defined PMS, which is quite interesting. And one of the things that might reflect a little bit as we're going on, when she tested women with severe PMS, they had normal progesterone levels. Think about that. So
those were blood levels, I'm sure you're referring to, right?
Yes. So in spite of that, she felt progesterone was a key, and she herself had catamenial epilepsy, meaning that every month she would have seizures.
Wow.
And
Katarina did? Katarina?
Yeah.
I did not know that.
So she introduced progesterone, found it did enormous things for her. And as I'm hinting at, as she had normal progesterone levels, I wonder if the patients that were suffering these horrible PMS symptoms had a load of estrogen, not really detectable by any testing. Estrogen and hormones compartmentalized. Yeah. We can't detect that. And what if their burden of estrogen and estrogen-like compounds were so high that it took, in this case, it's enormous amounts of progesterone to reach some degree of calmness for all those PMS type symptoms. So we were introducing, this was work by Hargrove and Maxon, using progesterone in oil and encapsulating it. Katarina Dalton used suppositories. So they were looking for an easier way to use progesterone. In the previous textbooks, it said progesterone was not available orally at all. But what had happened was we got to micronization of the powder, and then the realization that using an oil would help the absorption. So they did the work. They could prove that you could get some degree of serum rise with progesterone. And the best thing of all was that you could get symptom relief. So we started out with a severe PMS patient would get 100 milligrams of progesterone in an oil-filled capsule 4 times a day. That was the low end. We might need to go up much higher. At the time, I found the highest dosage of all dosage forms because very quickly we started doing rectal solutions, vaginal suppositories, skin creams, skin gels, troches, and anything to get enough progesterone into that woman for relief of her symptoms. And that's what I saw worked. Not 100%, and there's contributing factors to why it might not work so well, but these huge doses of progesterone really, really did work. So after a while, I got to thinking is why do we have to go way up here with progesterone? We might be meeting the demands of some huge level of estrogen. And both of those things aren't really the normal. Mm-hmm. And if we relieve this burden of estrogen, would we not be able to go down with both things? And in the last 30 years, we've learned a lot more about this estrogen burden. We've learned so many things that contribute to too much estrogen effect. And it's not simply your own hormones, although sometimes that's a problem with a bad microbiome. You recycle your own estrogens, and you can get massively high serum levels in some cases. And then you would suspect that this intrahepatic recycling of hormones is going on. So you can address the gut issues. Or you don't have good liver detoxification. You're lacking sulfur groups, you're lacking methyl groups to detoxify the estrogen. Or you have mercury amalgam in your mouth. And we have metallic estrogens. Heavy metals will sit, some of them will sit in progesterone receptors, and some will actually intensify the estrogen effect. So there's so many things that you can't start peeling away. Or how about candida? Candida can be a really big issue, this disordered gut thing. But some organisms in your gut, when it's not performing like it should, can actually produce 17-beta estradiol. Others can block all your estrogen. Just hang on to your estrogen. You're like estrogen stripped because of what's going on in your gut. So it can be a little more complex than you would think, but it's entirely learnable. And I think people in general are learning this faster than their medical providers. And the trouble is they're getting very little help from their providers. The good thing is people are starting to take charge of themselves because they're not getting the answers they need. And thank God for the internet, even though it's a morass. If you like the old show, the truth is out there if you start looking for it.
Yeah. So let me pivot a bit and just expand this somewhat. With respect to progesterone, many people see their doctors and they give them what they think is progesterone, but they give them a progestin, and they don't tell them that. It's a fraud. And a progestin is a synthetic progesterone, so they can technically get away with it, but it's the exact opposite. It does not work the same. It won't work. It's closer to estrogen than it is progesterone. So never, 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 never take a synthetic progesterone. Never any reason for it. That should be barred, outlawed. And then, so would you agree?
Yes, I would agree. It's very ironic that after Russell Marker perfected the semi-synthetic production of progesterone, I think that's a little important point. Prior to that, our only source of progesterone to use therapeutically was to get placentas and extract progesterone from there. So it was hugely, hugely expensive, but I believe that first came available in France. So Russell Marker.
And what was the year around, approximately?
Oh.
Was it, what century was it? Was it 19th, 20th?
It's like 1950s, 60s.
Okay. So it's not over 100 years ago. Yeah.
Okay.
No, almost 80.
So this is when progesterone became commercially available. And so he extracted a steroid, that means cholesterol-like molecule, from wild yam, altered the add-ons to that main 4-ring structure, and created progesterone. However, it wasn't long after that the first progestin was created, and it was norethindrone, so slight alterations to that ring structure. So both are made by the same process, semi-synthetic, synthetic altering of a natural compound, but the activity, when you change any little thing in a molecule, changes what it does. And that got to be a crucial issue. So now we have the first birth control progestins not long after we got progesterone. Progesterone is needed to carry a fetus to full term. Progestins will give you, you won't be able to implant. So interesting, back when I was a pharmacist way back then, we had one of the synthetic medroxyprogesterone acetate.
Provera, otherwise known as.
Provera, yeah, was used as a pregnancy test. Women would get a prescription for 10 days of medroxyprogesterone acetate. And if they bled after that 10 days, they were not pregnant. If they didn't bleed, they were pregnant. And that was a practice that was going on pretty actively. Then they discovered they were creating birth defects.
Yeah, I was going to say, at what price? yeah, they're going to just causes fetal damage for sure.
Yeah, just let that settle in. What is it doing to your body when it's destroying your baby?
Precious baby,
horrific.
innocent as can be. Never did anyone harm. Yeah. So
Katarina Dalton really opened the door. It was quite revolutionary to be using progesterone, and it had to be compounded. Let's
stop there for a moment, because you made a really important point, and that it was derived from wild yams, I believe, right?
Yes.
Because it was you can't extract it from human or mammalian tissue because it's too expensive. So it had to chemically alter it. But I just want to make a point here that the chemically derived and modified natural progesterone from yams, or progesterone from wild yams, is identical to the one our body makes. Would you agree?
Yes.
No difference. But when you make it, so this is a little key that you can use. It's kind of like a workaround. But if you found a product that had natural, or that had wild yam extract, this is kind of like the code word for raw milk for pets. Okay? Because it's not legal. It's not legal. You cannot buy raw milk in almost every state. Maybe one or two you can buy it. Maybe more. I don't know. I don't know the current legislation, but most states you can't buy it. But you can buy it as for pets. And everyone knows no one's giving it for the pets. Same thing with wild yam extract. You cannot buy progesterone without a prescription. It's a prescription.
That's right.
It is a prescription.
Way back when there became some products that were small doses of progesterone, 20 milligrams, 30 milligrams per dose. And indeed, they started labeling extract of wild yam because of FDA pressure against using the word progesterone. So you could argue this is like mislabeled or misdirected, but it was an effort to get something very valuable to people that was forcing an obstacle. I guess when you find an obstacle, you find a way around.
You find a way around. It's like when you hit a brick wall, you pivot. Hit a brick wall, right. Pivot. That's what you do. I mean, if you want to get results, right? So that's a point of information that people know that this is what you can do. Right? You look for things like this, and you can try it, because some of them may not be the correct thing, but there's no way you can know because it's illegal to put it on the label. And if it makes a difference, then it's probably a good chance it's working. It likely will. All right. So anything else you want to say on that before we go into the testing? Because testing is something I really want to dive deep on.
Okay, let's do testing. I wrote a blog yesterday on that very thing. So I also have a blog on my website about the various tests available for hormone testing. And I put the pros and cons or pitfalls of each type. But this time I pivoted on the blog I wrote yesterday because I wanted to point out how to pick a test or do a test that will give you information that you need or will direct you to action that you can rely on. And there's a lot of big problems with when we want to test something. Will it give you information that you need, something you suspect but maybe don't know? Will it confirm that? Can you get that? And importantly, if you have an action step from that. And I kind of built it around methylation and the use of hormones. As I mentioned before, methylation is an important detox step done by the liver. But how do you determine if somebody's methylating well or not? And if you don't do that, if you go do a test and you simply check some sex hormones, or you in saliva, blood, urine, whatever, or you simply add adrenal hormones, you have such a small piece of the picture, and it's easy to go awry when you also it gets even messier when you start supplementing and thinking the test is going to yield your success or not your success. So let me give you an example. People measure, let's say, serum estradiol, and they have a certain number. Unfortunately, people now think they're that number. And let's say for a menopausal woman, it's 50. And they read in the literature that doctors are saying you need to be 100 or you need to be 150 for good estradiol treatment. Yet it's only a number. It's very dependent on the time interval from when you took a dose to when you drew your blood. And say you have a dose the night before, you go in and have your serum drawn for estradiol, it's still 50, even though you took some estrogen. So now you think, oh, I'm not absorbing anything from that. Well, it's really wrong. It came and went in the serum in the 3 to 6 hour time frame. And when it dropped out of the serum, where'd it go? You got rid of it, you detoxified, got rid of it, and you went to your tissues, exactly what you wanted it to do. So I go to Facebook.
At least you thought you wanted it to do. Because
Right.
that's
At
exactly
least
what you don't want it to do if you know better.
I bring up estradiol because we're sort of wanting to talk about estrogens. And I bring that up because I go to Facebook. If you have the time, it's a really good place to find the failures who are trying to use hormones. And in so many websites or Facebook pages, women are being told, yes, you need to be 100, 150. You need to have that number. And so if you actually took your estrogen and couldn't measure a change, now you're told to use more, and then more and more estrogen related symptoms just blow up, and women are telling each other you still need more estrogen, and it's a horror thing. Jerry Lynn Pryor did some really interesting research. She said women have the highest level of estrogen in their whole lifespan during the perimenopausal years. However, when you start having symptoms, doctors dose you up with estrogen. It's not the hormone that's deficient. The first hormone to drop is progesterone. So coupled with the most estrogen of your lifetime, and now you're starting to have missed ovulations, which means you don't have this lovely surge of progesterone in the luteal phase. You're flatlining to whatever your adrenals can be doing. The difference between your estrogen effect and your progesterone effect becomes miles apart. And you are having a lot of symptoms. You're anxious. You can't sleep. You get headaches. You go into rages. You're
breast cancer.
Yes, this is a really, I think it's debatable whether estradiol is the initiator, but we have so many chemicals that are
Similar. It's
estrogen
estrogen
like.
dominance. It's that dominance. Yes. Yeah.
Yeah, this is a very, very bad place to be. I think your breasts should be in good shape. In fact, this is my first experience personally with progesterone in my 40s. So I started using an over-the-counter cream, 30 milligrams of progesterone a day. I put it on my face. Progesterone is really good for keratin and collagen and all this, as is estrogen. So those little wrinkles at the sides of your eyes that you get about that age can be progesterone dependent, I read. And so I decided to start using it. About 4 months later, almost all the fibrocystic breast disease I had suffered with for a couple decades at that point disappeared. I was down to one lump that had been the biggest and it retreated. And I talked to Dr. Eugene Shippen about that time, and he goes, oh, add a little iodine. And he said, with iodine and progesterone, we get rid of lumpy breasts all of the time. Yet I talk to women day in and day out who are suffering with fibrocystic breasts, painful breasts still. And I think that's really a good red flag for knowing that you are severely out of balance with your estrogen progesterone. I think it's a great one. And guess what? If you have breast pain and you use progesterone, you can get rid of that pain pretty quickly, as long as you're using enough for your needs right at the moment.
So, curiosity, did the progesterone around your eyes get rid of the crow's feet or what?
Not so good.
It didn't work for that. It worked for the other things. And okay.
Yeah.
So I wanted to comment on the fibrocystic disease because Georgie has brought up quite frequently that one of the big problems with cystic issues is really increased serotonin, which is the precursor is tryptophan. So if you're eating a lot of tryptophan or taking 5-HTP before you go to bed because you're not sleeping well because you have too high of estrogen, you're compounding the problem for this because you're going to create high serotonin. And serotonin is somewhat similar to estrogen. It's okay, you need a little bit, but you do not want excess. Excess is no bueno for you. No bueno. Would you agree that the serotonin could be a contributor?
Yes, I agree.
Okay.
Entirely. But it wasn't on our radar at that point so much.
Yeah. It was something newer. I think I'm pretty confident Dr. Pete helped facilitate that awareness. So I wanted to make it very clear, because we didn't really go into it, the issue of testing estrogens, because this is commonly done. There are many good tests out there, like the Dutch test, and I love the person who developed this. But I think in some ways it's not ideal because you're measuring tissue that really doesn't reside. It's not in high quantities of the blood, as you referenced earlier.
Right.
It's in the tissues itself. And if you really want to know what the estrogen level is in your body, you have to measure your tissues, and that's not practical. You're going to have. We were talking yesterday. You could do it's high in the peritoneal fluid, but then you'd have to do a biopsy, a peritoneal biopsy. That's. I mean, you could do it. You can get away with it, but there's some risk to it. And it's not worth the cost benefit. Or you can do a liver biopsy or muscle biopsy, you can figure it out. But you're not going to get it with the blood. It is not in your blood. Do not waste your money on testing blood. It's an absolute waste. We are going to have a world-class blood testing system available for you very shortly, if it's not already implemented by the time you view this. And we will not, and people will be able to test any test they want, but I'm not going to let them test for estrogens at all, ever, because it's a worthless test. Do not do it. Do not do it. But there is a test you can use, and I don't want you to tell us what that test is, and better yet, explain why it's so good and how it works, and it's a fraction of the cost of estrogen test.
It's prolactin. And this is from the genius of Dr. Ray Peat. He said prolactin increases unless there is a pituitary tumor. It increases when estrogen effects are high and thyroid is too low. And so maybe that low thyroid effect comes from the high estrogen, because high estrogen can suppress your thyroid functioning. And so I'm asking to see that test more and more, because I think it's more reliable. It's a functional test. When you do like just a blood test, you have a moment in time, and it doesn't in spite of what many labs try to claim, it doesn't reflect your whole body status because of things compartmentalizing all over the place. So it's like you could pick any number out of your butt and say that's what you are. And that's virtually what's happening. So prolactin gives you this functional test. So you see somebody with higher prolactin, guess what brings that down? Progesterone. And high prolactin is a marker you would see in like prostate cancer and breast cancer. That would be surging very, very high. And the thing is progesterone. I heard a lecture by Frederick Dawes in Germany. He's got St. Georg Clinic many years ago, and he was talking about prostate cancer and high prolactin and recommended bromocriptine. And so I asked him later personally, I said, why don't you recommend progesterone? He goes, well, you could. And the funny thing is, a few months ago, I found a video of a recent lecture by Dr. Dawes again. Guess what he's recommending? Progesterone.
Natural progesterone, not progestin. Yes.
Right. He finally learned about the hormones
Came around
somewhere along the time in between the two meetings. I was just absolutely delighted to hear that.
Well, he doesn't have stakes in the grounds and wasn't rigidly adhering to previous beliefs and, willing to admit that he was wrong, which is a good process to have. So the estrogen, as you mentioned, it stimulates the anterior pituitary to secrete prolactin. And if it's and I want you to go over the normals, because if you have a double digit prolactin, you're in big problems. Big problems. It should almost be half of that, but certainly below 7.
Yeah, I was just going to say 7 or 8 would be acceptable. There's another problem. Consider this. All these poor women who have suffered with a hysterectomy, which in my mind, almost 100% of hysterectomies are because of a history of low progesterone and totally unnecessary if interventions were made earlier. So these women are given what? They take out their uterus, they take out their
estrogen,
and they give them estrogen. Your ovaries were responsible for a lot more things than that, and you're totally out of balance with one hormone. So then the sequence is your prolactin is going to rise because of this intense estrogen stimulation. You're being told you have to have estrogen to protect your bones, but your doctors are actually creating osteoporosis. The high prolactin in turn stimulates parathyroid hormone, which sucks calcium out of your bones. It's so incredibly stupid. This thing about women with hysterectomy do not need progesterone. We've solidified this lie.
Well, that's true. They don't need it to protect against endometrial cancer. That's 100% accurate, because there is no endometrium. It's gone. They took it out. Right. They yanked it. But that was a minor thing compared to what else you need it for.
Yeah, you need it all over your body for many, many things. One of the things that strikes me about progesterone is that we still know so little about everything it does. It's made independently in Schwann cells, along with pregnenolone, and it helps keep your myelin sheath healthy. It's made independently. You have a whole hormone factory in mast cells. And when estrogen dominates, histamine's released. When progesterone is enough inside the mast cells, then you have no histamine release and side effects of too much histamine. It's incredible, but your brain makes progesterone independently from cholesterol. We have progesterone, little intracrinology.
And actually, I don't know if you've treated this, but one of the newer indications is neurodegenerative diseases. So, and things like autism, the spectrum disorder. I mean, you can make a pretty strong argument that progesterone should be given for any child on the spectrum.
Absolutely, and if you would see that on a test, an untreated person, you could measure for progesterone at that point, and you'd see none. But
Yes.
Just given the symptomatology, you can come to the same conclusion if you understand what progesterone does. I was at a conference. This neuro stuff is quite dramatic. And this is nice because exogenously given progesterone actually is used by those cells that were making it independently. So I was at a conference, a pharmacy conference, and I listened to the first lecture of the day, and later at the reception, I talked to this same gentleman, and he told me privately that he thought he might fall over because he could not feel his feet while he was giving his lecture. I gave him progesterone to rub on his feet. The next day he comes over, he said, "What have you done to me?" He comes dancing over. He's feeling his feet just like that. Unbelievable. How much neuropathy do we have in our country? And
So something.
have people been given progesterone, pregnenolone as a first line to treat that? I bet not.
Yeah.
And
And you could use a prolactin level. I want to mention a point because I mentioned the blood test we're going to have, and hopefully it might be available when we air this interview. But you know how much a prolactin is going to cost? How much do your patients pay for it? You see this all the time. You've been doing this for decades.
yeah, I don't know. It's usually part of a panel, so I couldn't give you an individual
But
test.
it's not terribly expensive. It's less expensive than
No, no.
estrogen. But we're going to sell it for $4. $4. That's less expensive than you've ever seen it. So it's affordable, folks. I mean, it's less than a cup of coffee, and you can do it serially to see how and monitor your therapy. But the other point I wanted to make this, and I want to pivot to a little tangent that you mentioned with the osteoporosis and estrogen, is that it's also a good screen for anything that activates the estrogen receptors, which would be plastics, because that's the way plastics harm you. They activate estrogen receptors. There's also called EDCs, which is short for endocrine disrupting chemicals, but fundamentally it's an estrogen receptor activator. That's what it should be more called. It's ERA is what they should be called, estrogen receptor activators, not EDC, or estrogen dominant activity, because that's what they cause. So you can use, and I suspect you've done this clinically, I haven't, but you can use that as a marker to see your microplastic exposure, which is pervasive. So if you have
Yeah.
a high prolactin, I don't care what the source is, you're still going to benefit from progesterone, even if it's from microplastics.
Yes, and I think that's what we see when we're forced to use higher amounts of progesterone just to get relief. That you're
Yeah.
dealing with a lot of stuff, and it's difficult. Like, what else do you do besides sauna to really get plastics out of your body, or sweating?
Yeah, well, progesterone, I would say. That's why I
That's
think you can make a pretty strong argument if you haven't realized already that I think you could make that almost every adult should be on this. I'm not suggesting, and that doesn't mean it's a magic bullet. That means you have to address the other areas of life. But we're in this toxic chemical soup, which consists of the plastics, the estrogen that we may or may not be exposed to, but certainly the plastics and the linoleic acid, the seed oils, the vegetable oils. This is what you're just getting smashed because it activates the same receptors indirectly, and it just destroys your mitochondrial function. So we're just getting whacked. And then stresses, cortisol, progesterone. We didn't even talk about that. It's an anti-cortisol blocker, anti-adrenaline. I mean, it
yes.
literally is a miracle thing.
This is
I
a
mean,
huge piece with adrenaline and the cortisol relationship, and I think it's driving a lot of symptoms in women. Those women who are experiencing their heart beating out of their chest, huge anxiety, not sleeping for days, they finally go to the emergency room. What do they get? They get a full cardiac workup, might take days. Something's wrong with your heart, right? It's not something wrong with your heart. You're reacting to the imbalance of these hormones. They should be given progesterone in the emergency room, and it will stop the whole thing. And then back to what you've covered in your book very, very well.
Wait. The book you're referring to is the one that you got to read before it was published. We're recording this before the release date. This interview will definitely be out after the release date. It's Your Guide to Cellular Health: Unlocking The Science of Longevity and Joy. Really good.
Yeah,
What do you think of the book? What do you think of the book?
I like the book. Since I've been a fan of Ray Peat for a long time, this was very I understood it quite well and know the principles, but people don't have access to all this information, and I like how you sorted it out. Reptilian brains like order, and so when you pull together, repeat actually could be all over the place, and if you follow
Oh, he
his
not
stuff for
could
a
be.
long
He
time,
was, which is
and
which
which
made
is
him difficult to understand, and even more difficult to comprehend what he was teaching because it was a giant 10,000 piece puzzle. You had to pick up pieces here and there, and eventually you have to create the order yourself because he never did it really well.
yeah. So you did a masterful job of bringing order to these ideas,
Yeah.
and that's something our reptilian brains love order, and that'll make it easier for people to understand these concepts. And I love that you bring the huge danger of the polyunsaturated fats. I wanted to bring up earlier melasma. The brown spots you can get it after pregnancy, you can get it anytime. Theoretically, progesterone should be good for that, but I can attest it doesn't clear it up entirely. And you brought in the polyunsaturated fats have a lot to do with that as well. So progesterone, even though I love progesterone and I think it's amazing, there are places where it's not the whole thing.
Well,
And I
as you
think,
mentioned, it's not the magic bullet. It's part of the program for
yes.
sure for virtually everyone, but it's not a magic bullet. It may
And,
look
and
like it, but it's not.
And of course, I love that you made progesterone a pillar of the program, which of course I wholeheartedly agree. The only shortcoming of saying this is so important, or it's not the thing, and as you said, with your several pillars, with the EMFs and the phony estrogens and so forth, and the PUFAs. It's all pieces of the puzzle, and how you're eating. And this is going back. Insulin and glucose are the most primitive and most powerful hormones. And when you're off with your insulin resistance or having blood glucose swings, that's when you set into motion these huge adrenaline surges. And then if you can't methylate, you can't get rid of that adrenaline very easy. You have like steady state anxiety, and your cortisol's going up trying to balance it. Your progesterone's getting sucked into helping. And we call the endpoint of that something like adrenal fatigue, but your adrenals are actually overproducing adrenaline, not getting balanced properly. And I see that as a huge problem when you have these symptoms that are simply relentless. And because practitioners don't have a clue, their patients don't have a clue, and everybody feels helpless. So people need this information to take control. I have a radio program, take charge of your health. Same thing. People need the information so they can become the observers. They can biohack themselves. They can figure out what is needed, why it's needed, how it's needed. And your new book is a powerful path forward for that information. So congratulations. I did like the book.
Thanks. Yeah, we actually had a conversation yesterday, which actually catalyzed me to understand that I need to talk to you on an interview. So we did. We were able to fit in our schedules, and that's why you're here today. And during that conversation, you had brought up the fact that you had seen some people recently, and you had read my book, and you were wondering, these were people who were low carb, some carnivore, that literally there's a very sensitive test I talk about in the book, we won't hear, but it's called HOMA-IR, which measures insulin resistance. And Dr. Shanahan has reviewed the studies on that and believes that only 1 out of 100, maybe 1 out of 1,000 people have normal insulin levels or not insulin resistance. And I suspect your experience would support that. Well, you saw a woman who was one of the 1 in 1,000. She was not insulin resistant. Yet you did a glycohemoglobin, hemoglobin A1C, and it was elevated. And it should have been. She has no insulin resistance. Yet how could she have a high hemoglobin or high glycohemoglobin? And then another woman was virtually on no carbs. She was on carnivore, and she would have the same thing. And the issue was they were making cortisol and adrenaline, but primarily cortisol, that causes the liver to make glucose out of proteins in your body, which is not a good strategy, not cost effective, but energy efficient. You're losing energy when you do that. It's not net gain, it's a net loss. And to get that energy in form of glucose, but if you don't have it, you're dead. You will die. 100% you will die. You go hypoglycemic. Your brain requires glucose. It cannot survive on ketones and lactate. It cannot. It needs a minimum. If you don't have ketones and lactate, you're going to need about 150 grams a day just to stay alive. If you eat it, it's a lot easier because your body's going to have to make it. And if you're making it, you're making cortisol, and it just screws everything up. You get insulin, not necessarily insulin resistant, these two people that we said, which is why it's confusing. Because I was fasting too. I would be fasting and I wake up with blood sugar 105. What the heck's going on? It makes no sense. I haven't had carbs in
Yes.
days, I had zero carbs. But it happens. Your body has to rescue you from your stupidity and create them to prevent you from dying. Essentially what happens.
Well, it brings up another point of the importance of enough protein. And we have, as we're aging, we don't have enough protein to allow our bodies to function, and then couple it with decreased digestive strength to break down that protein so you can use those amino acids. So sometimes people are taking drugs because they're getting reflux, but it's absolutely the wrong thing to do. They're limiting their protein because they feel they can't digest, yet that's going to kill you too, because you can't make
for sure.
your body structure and its metabolism. You just can't do it. And so that's why look around and you see the aged and they're shrunken people. They can't maintain their body structure. And that goes true for all your muscles and your bones, and everything is dependent that you get enough protein. So that's an important piece. But you also need the carbohydrates along with that, and you need some fats with that.
Well, you need saturated fats, not the PUFAs, for sure.
Yes, not the PUFAs.
But you could literally, it's almost impossible to eat food and be PUFA deficient. I don't think you can, actually. You'd have to eat a lab diet, because almost every food has enough PUFA to keep you alive, which is a half a gram a day. That's all you need. Maybe a gram, but probably 500 milligrams. And you cannot eat real food and not get less than that. It's like impossible, because watermelon has it in it. There's no fat in watermelon. And I'm not talking about the seeds. I'm talking about the fruit itself. So, but you had mentioned the protein and the contribution of osteoporosis if you don't get enough, and the acceleration of osteoporosis with excess cortisol. But earlier you mentioned the connection to estrogen. And I wanted to ask you a question about the calcium and phosphorus, because I think you do some testing in parathyroid hormone. So if you could go on, we wanted to screen, well, progesterone will help build your bones, no question. But there's a number of things to build bone density. I think we should take a little pivot here on osteoporosis, how to build strong bones. First of all, you need protein, but almost no one understands this. I've seen people who are passionate about this and did osteoporosis screening clinics. They were unaware that one third of bone is collagen.
Yes.
Collagen. And if you're like the average person who's eating less than 5 grams, less than 3 grams a day of collagen, connective tissue, then you can't make healthy bone. You got to have 130% of your protein is collagen. So that's the key thing. Protein. It's very specific amino acids. There's proline, hydroxyproline, and glycine. If you don't have that, you cannot make healthy bone. So, but the other thing is it's the calcium to phosphorus ratio. And a carnivore is a disaster for many people because their phosphorus level goes through the roof. And if you're not compensating that with extra calcium, phosphorus is a very powerful aging molecule. Excess phosphorus. You need some, otherwise you'll be dead. But if you get too much, which is most everyone's doing, this is probably a reason why soda is so bad, because of the phosphorus.
Right.
It really isn't the sugar; it's the phosphorus. Phosphorus is not a good molecule. So I want you to share with your clinical experience on using the serum calcium, serum phosphorus, which is not typically available. You need a very special panel. It's called a metabolic profile or chem panel 20. And the ones they do now are 12 and 14. And they forgot to measure phosphorus, but you can order it separately or you can get some bigger panel. So calcium, phosphorus, and then the parathyroid hormone that you mentioned, referenced earlier. So walk us through your analysis of determining if you're in the right levels to build high bone density.
Oh, that's a little bit above my pay grade. I have seen this from somebody was suspected of being high parathyroid and did this whole panel. So I've seen it, but not too much. And you're absolutely right. It's like so rare to have too little phosphorus. I actually saw one the other day, which I was.
It can happen. Yeah, it's very rare. But it's the ratio. It's the ratio that's key, right?
Yes.
It's like
yes.
that, and you want to get it on the low side. You don't want it on the high side. It's like 1.1 to 1.3, but you can go all the way up to 1.3. You don't want to go much higher beyond that. You know, essentially, it's almost, if you look at the levels, it's almost like 3 to 1 or 4 to 1. But when you do the ratio, it comes out to 1.3 to 1.
Right. So what you're talking about really is a good example of a functional test.
Yes. Yeah.
And that's what you order when you want to have some real information that points out the issue, and it could be a silent issue, and you'd like to get that information. It also gives you action steps, like what direction you're going in. So that's an extremely important point about choosing your tests. You want a test exactly like this that gives you some information that you can act on. And the other thing is you can repeat the test later to reveal, to
see if it's working.
To see if it's working. And not all testing yields that kind of information.
Yeah.
So I haven't been exposed
in the process.
to that much,
Remember,
but that's
okay. So we're going to screen for it because there's testing that we're going to offer. You can basically get any test you want, except they won't let people order an estradiol test at all because it's worthless. They're wasting their money. I won't let them waste their money. But any other test, we're going to offer like a serum phosphorus, calcium, insulin, glucose, parathyroid hormone, ferritin for iron excess, thyroid panel, lipid panel, C-reactive protein for inflammation, serum magnesium, and all that we're hoping under $40. Most people would pay over $300 for that. All that, and without a doctor's order.
Yeah, that's simply incredible.
Affordable.
Okay. So you're opening this door. So I'll ask the question because sure. What you're thinking about. So you have the opportunity, and there are direct to consumer labs available now. But the problem is you get your results and you're not the lab.
Don't know what to do with them.
You don't know what to do with it.
Well, not at my lab because we tell you what to do with them. Because it's a wellness consultation. It's not disease. It's interpreted. Over 30 years, I put together rules how to evaluate these things, and the software that we have will essentially tell you how to interpret that. What is the calcium phosphorus ratio? How do you need to increase your calcium? All these things that there's no way you can know unless you look. And so you have an affordable test and the rule and essentially a software consultant to tell you how to evaluate it.
And it gives you much better information than if you go to your doctor and they tell you, well, the current treatment for osteoporosis is take some calcium and use a bisphosphonate drug.
Yeah, like Fosamax.
Yes. And that's a kiss of death too, in my opinion.
Yeah, for sure.
So you're killing your bones.
Yeah. Yeah, because people don't know that's a poison. It kills osteoclasts, which are the ones that eat the bones. So you get a bigger, thicker bones, but it's not denser. Is what you need. The strength isn't there, and you actually increases the risk of fractures, which is what you're trying to prevent.
And then if you do have a fracture, you can't heal it. It's a big problem.
Because the bone's dead.
Yes.
Yeah, let's kill your bone. They love doing that. They love doing that. They love killing things. That's their thing, killing things. So Carol, you are a pharmacist. You are
Yeah.
probably one of the best qualified people in the entire world, because not only are you a pharmacist and you're familiar with dosages and route of administration, but you have decades of experience using this, more than most anyone on the planet. So tell me about the dosages, because it's so, the range of dosages in your specific conditions. And then after you complete that, I want to go about the route of administration and differentiate between transdermal, transmucosal, and oral. And any other way, well, even transmucosal would be a variety of things like your gum or your under your tongue or the rectum. Those are all
Oh,
transmucosal.
yeah,
But
vaginal
so
rectum.
we'll go into that, but go into the doses first, because we need, now we know why and the benefits. Now we need to understand how to do it.
Okay, so I would say a lot depends on what dosage form you're using, and I believe that progesterone in general is the defining thing, and it has different types of activities, metabolism, whatever way you use it. But the best absorption is transmucosal, either vaginal or in the mouth or rectal. You can have suppositories, inserts, lozenges, oils, all kinds of things to get that progesterone in, and that's probably the most efficient. Yet creams do work, capsules do work. I've seen it. The doses have to be pretty
All right.
large.
Well, yeah. So that's a higher dose if you use a cream. In my experience, based on John Lee's Catalyst, was I used for many of my patients, actually maybe most of them in the 90s, I used the transdermal, and it worked almost every time. But then it stopped working. Literally 3, 4 months, very consistently would stop working, and they didn't know I didn't know what to do, because John Lee was my only mentor back then. So we should have been transmucosal. But before we go there, let's go back to the route, or actually the progesterone is dissolved. You mentioned the oil, but talk about Dr. Pete's innovation. And people don't understand that 1972, the year you got your degree, Dr. Pete got his PhD. And you know what his PhD was in?
Here's biology.
No, it was estrogen. He wrote his dissertation on estrogen.
Oh my gosh.
Yeah, he did, 1972. So he was the expert for sure. But anyway, he came up with one of his passions was progesterone also. And he figured out, I think, probably the best way to dissolve it because of its molecular structure. And he's a biochemist for
Yes.
sure. Molecular. So tell us about what he does, because I think, it was vitamin E, of course. And I
Yeah, he
think that is,
dissolves it in
if you,
vitamin E, which
yeah.
has further property. It not only can dissolve the progesterone, which is a huge problem, and that's one of the problems with creams. All of that progesterone is not dissolved. Until it dissolves in your skin oils, you can't get it in.
Mhm.
So that's sometimes why more is needed. But it's really brilliant because vitamin E, as its antioxidant effects, also help. It's also an active ingredient in helping you
Mhm.
balance that excess estrogen activity. So really, really and truly very brilliant.
And PUFAs too. And estrogen and PUFAs
Yes.
are really similar. Estrogen dominance is related to PUFA because they have many of the similar activities. They have the same mechanism of action, which increasing intracellular calcium levels, and it increases water retention. They both do the same thing. So the vitamin E, I think, inhibits lipolysis. I might be confusing that with aspirin, or maybe they both do it. But I thought it had an effect on lipolysis, so that it prevents the PUFAs from being liberated from the
Right.
fat cells.
Right.
Yeah, yeah.
So it's just absolutely brilliant and probably the best way to deliver
Is
progesterone.
that your favorite route recommendation?
I'm a little less picky because people don't have access to all that they could. I
But if
really,
you if you had a choice, you work with people where they're at. But
yeah,
if they were asking you what would be the best, what would you
yeah.
recommend?
I would say transmucosal, and of course, because it's dissolved, it has to be dissolved to get through transmucosally or through the skin or wherever. You could put it in other parts. That's really super important to getting the hormone into your body. Undissolved is just going to sit there. So it's
Or if you swallow it, let's go into the oral route, because we don't recommend this at all. No one's recommending oral swallowing your progesterone. Not a good idea, because, or
the
maybe you are. Maybe I'm
no,
confused.
no, no. The OBGYNs are. That's the only way you should use. It's the only way
Yeah,
you
of
get
course.
a serum level, and that's the only way you know you protected the endometrium, which is all false.
Both of what, all wrong. All, they've got it totally backwards. Totally backwards.
So, but I know oral progesterone does work. It does. It gives you symptom relief as progesterone should. And there's two kinds. You can have progesterone in oil, progesterone not in oil, but you could eat something fatty with it to improve absorption. And it goes into the lymphatic system. It's absorbed like a fat. So some of this criticism that it's just destroyed in the gut acid is not true. They've verified that it gets picked up by chylomicrons like a fat. So it's a bit complex.
But does it go through for liver metabolism and actually metabolizes and detoxifies it? So it's not active in the metabolites. Aren't too bad though.
Yeah,
They're not dangerous in this case.
right. Everything goes through the liver. That's another problem. Like people will say, "Oh, since I'm not having it orally, it doesn't go through the liver." That's the first liver pass effect. It's a technique to intensify the active ingredient for a short time before it gets to your liver. In seconds, your whole blood goes all over your body, under 2 minutes, 90 seconds, some people say. You're going to your liver. What protects your liver with bioidentical hormones is you're not introducing foreign chemicals to your body and stressing your liver with trying to detoxify whatever foreign chemical you put in.
All right, so let's go to the doses now. So we've got the route of administration, and you made a really important point that it really depends on the way that you're administering it. But assuming it's on an ideal transmucosal route, then ideally is supplemented with vitamin E. And if you have some progesterone now, you could just combine it with vitamin E. Just break out the vitamin E from the kill. You just bite it or put a knife in it and liberate it, and just mix it up with your finger and put it on a spoon and put it on your gum, or put it in your vagina or your rectum. But the gum to me is the easiest, most simple. Some people don't like to play paper, but anyway, you do that. What are the doses and the timing and everything and the range of symptoms?
Okay, so that's a good question, because the doses become very, very individualized. The endpoint has to be relief of symptoms.
Okay, good point.
Every dosage form that you have. And I also, and Ray Pete wrote about this, one of the pharmacists I work with, cottoned on it. If you're in that zone where you don't have quite enough progesterone and things like anxiety are increasing, you need another dose, maybe every 15 minutes till you get to the calmness that progesterone.
And what is that dose? Are we talking 25 milligrams or so?
Okay, so with the transmucosal, it might be 25, it might be 50, it might be 100. I don't. Depends.
Oh wow, you can go that high. Okay.
And creams and gel creams. I've had people use well over 2,000 milligrams of creams.
Oh my gosh.
But I related in part to the severity of their symptoms, the lack of progesterone, maybe for decades, plus not getting absorbed as well. You can't say all of this on is in. So
so you never see that with transmucosal 2,000 milligrams. No, 100 milligrams maybe top. That's it. No reason to ever go more than 100.
Well, there would be a reason if you're not 100% free
so no
of
symptoms.
And I like anxiety because it goes quickly. You just virtually flip. You turn from a very
turning the switch off,
and it flips.
The anxiety switch.
And people don't believe it. I had some women who run Facebook pages in England with PMDD, and they were reading about how I encourage more use of progesterone. The women with PMDD have been told to avoid progesterone at all costs because Unbelievable, Dr. Mercola. This happened in the late 90s. The companies that made SSRIs stole the
Oh,
emotional symptoms of PMS
oh,
and made it a
criminal.
new category. And now you have to avoid progesterone, block progesterone, and these women live in agony. So
Oh,
I was so surprised. This woman who administered this Facebook page reached out to me and said, Carol, I and a few of my friends who have been suffering with this started using more generous progesterone, and they got their symptoms to flip. They've had decades of misery because progesterone was the missing thing. But someone with such severe symptoms needs a lot more than what you're talking about. If you're aging
yes.
gently and need some of that support, lower doses will happen. There are women that will do better with higher doses, at least for a while,
Yeah.
until their body's restored. And then they need probably another things. I think these women are not only are they having too much adrenaline, too much estrogen, their thyroid support, they can't detoxify well, and they're eating poorly for what's going on. So you need a multi-pronged approach
Okay.
to get to some comfort, but they will get comfort with higher doses, and they're willing to take progesterone in any way, shape, or form. But guess what? In the UK, primary practitioners are limited to using Utrogestin, which is the same as Prometrium, and
Which is
oral.
synthetic. That's synthetic. That's a
No,
progestin.
it's progesterone,
No? Oh, it's progesterone. Okay.
but it only comes in 200 milligrams,
Oh, geez.
100 or 200 milligrams, and that's anybody who uses it as a general practitioner would be sanctioned for overusing progesterone in the UK.
Wow, that's crazy. So, what about the doses for differentiation between dosing for a premenopausal woman, a woman who's still menstruating, and a postmenopausal woman? I mean, you could theoretically make a pretty strong argument for cycling in and out of the luteal phase. Do you still recommend that? I mean, but you alluded to the fact earlier that women still can do that and to get away with it. So, what's your current regimen recommendation for a menstruating woman?
Oh, if they're still, it depends where their symptoms are. They might need more generous dosing during the luteal phase if they're PMSy symptoms. But if there's anxiety in the follicular phase, a little progesterone could help with that in their sleep. If they might be having sleep problems all month long. You want to stick to if it was a cream or a capsule, probably around 100 milligrams or less. Transmucosally, I'm sure you could get along with less. You don't want to have progesterone so high in the follicular phase that you suppress ovulation, because then, of course, you're going to miss out on the lovely surge your body would make, which is far better than what you can put on or apply.
So, yeah, so let's take an average person who may not be having significant symptoms, but is concerned because they do their prolactin level and it's 15, 20, and they don't notice any anxiety or any symptoms. So they take it, and what would you suggest is the best timing? From my review of Dr. Pete's work, he liked to do it an hour before bed because one of the other benefits is it tends to increase GABA, and GABA, as we know, is a really important, powerful hormone, or actually not a hormone, but neurotransmitter to help facilitate sleeping well.
Progesterone there's two ways to help sleeping. One is its effect on adrenaline, which calms your mind so you can sleep. It doesn't put you to sleep. It allows you to sleep.
It just allows you to relax.
Right.
No high cortisol.
Alternatively, if you have allopregnanolone being produced as a metabolite of progesterone in larger doses, it's going to knock you out. That's very
sedative.
That's very sedative.
So what about the timing? Is it about an hour before bed?
That would be fine. I also like progesterone during the day.
Okay.
because you may be
If you have symptoms.
symptomatic all day
Yeah.
long.
Yeah.
Michael Platt suggests you use progesterone at mealtime. It has a way of balancing, bringing up low blood glucose, bringing it back up to normal. So those insulin glucose swings are moderated by progesterone. And
Especially if you're not if you're insulin resistant, like almost everyone is. But if you're
exactly.
not, probably not required. But if you are, consider it. I never realized that would be important, but that's
Yeah.
another good
Some
utility. And
women
what
will,
type of dose? 25, 50 milligrams, and is before the meal? Probably before
uh,
the meal, right?
just before the meal. And
Yeah,
really depending on what you have and what's working for you.
yeah, yeah. Yeah, so listen to your body, right? Your body's going to tell
Yes.
you. But symptoms. So if you're going to modulate the symptoms, what would be the primary symptoms you'd say to focus on? Anxiety, you mentioned.
Anxiety, because it flips so quickly. Also,
Okay.
breast tenderness and swollen breasts, that resolves
Mhm.
pretty quickly. It's not like the anxiety, like a light switch, but,
Mhm.
but it relieves. It's another thing. A lot of women, perimenopausal, menopausal women are walking around with sore breasts. This is
Mhm.
this is not a good state of affairs and should be corrected and can be corrected
Estrogen
very easily.
dominance because you're at high risk for breast cancer. I mean, this is a big deal. This is the number
Yes.
one reason why women die from cancer is breast cancer.
Yeah.
Number one. This is not a small deal. And it's to me, it's a crime. It's almost always an element of progesterone imbalance and
Right.
estrogen dominance. I mean, it's not
Right.
100%, but it's a major factor in most people. And if it isn't the major factor, it's a big factor. It's in almost everyone. So to me, it's almost criminal not to address this with
Yeah.
something so inexpensive and safe.
That's
It's
right.
just, oh, it's criminal.
Unbelievable.
Yeah. So now we can just go for it. What would you like to share and expand on? Because we've hit a lot. We've given a lot of information.
Okay, I would like to do a couple more points on progesterone.
Oh yeah. Go on for it, man. I love progesterone. It's one of my favorite molecules. And I think, as I said, every adult, this is men and women. This is not just for breasts. This is not because all humans have progesterone.
Yes.
And it's almost impossible to overdose on the thing. It's so safe. I mean, you can give doses when you're pregnant. What's crazy? Hundreds, a gram, 2 grams.
Yeah, I saw a lab that went all the way to 550 nanograms per deciliter, and
But
the
we're not measuring
textbooks
we're
regard
not
the
measuring in
food.
the blood.
No,
No, I'm talking about oral doses that you take. You could probably take grams of this, and we don't recommend grams, but it's
yeah.
safe. I don't know there's been any reported cases of overdosing of progesterone. I don't recall ever seeing one.
Now people talk about that, but it's usually inappropriate use of progesterone and how it's been used. I know some people have that in their
Or it's
books,
progestin, or it's progestin.
or it's progestin is correct. So I
Yeah.
want to talk about progesterone and bleeding.
Okay.
Okay, so we have the menstrual cycle chart, which says from ovulation to the first day of bleeding, you have this big surge, estrogen surges, progesterone surges. And the way we are all taught is progesterone and estrogen has to drop to bring on bleeding, bring on menstrual bleeding. And that's not true. And I learned it from the PMSers who took very large doses of progesterone, and they continued 1, 2, 3 days into bleeding because they still had symptoms. PMS symptoms were still there, and they bled on time. They were extremely regular.
Wow.
It was not a drop in progesterone that brought on the bleeding. It's something else. I don't know what it is. Somebody can go get a
Wow, it's
PhD,
interesting.
work it out on that. But progesterone has a biphasic activity in the luteal phase. The first part of the luteal phase, it's enhancing the progesterone directed building up of the endometrium. You're preparing for the fertilized egg. When it reaches its highest point and there is no egg, it flips into being a secretory hormone.
Wow.
It assists in breaking down that tissue so you can shed it.
Who
So
would have known?
here's my point. So if you've been without progesterone for a while and you start progesterone, and there's some endometrium buildup, let's say you're not cycling, but you're menopausal and you're going to have some hormone support, that endometrium at some point is going to be secretory because of the progesterone, and you're going to bleed. So too many practitioners and women are trained to be afraid of supposedly abnormal bleeding. Off you go to the doctor again for big workups. And if you're actually bleeding and you have a transvaginal ultrasound, you're going to see the endometrium's looking okay because you're shedding it out. So you're already at the solution, getting rid of a built-up endometrium. So this is a scary thing. And if you're starting on progesterone and you have some tissue built up, it'll help you shed it, and that's good. That's wonderful, and you're not having cancer. The same thing applies. There are some women that have such enormous need for progesterone. On one Facebook page, they call this estrogen kickback. With the lower doses of progesterone, you can actually make estrogen-related symptoms worse. Like you can have more headache, more anxiety, more breast pain. Let's say you started on 10, 20 milligrams. A lot of practitioners, this is the dose they're giving their patients, and it makes them worse. And they hate progesterone when the dose really needed to be high enough to overcome that. As I said, one Facebook page calls it estrogen kickback. We used to call it, when we had the higher doses of progesterone, that you'd have a breakthrough. If your symptoms were kind of returning when you had a certain level of progesterone intake, you just take more progesterone and get rid of that immediately. So things like anxiety, breast tenderness, you can get rid of this the same day. Headaches, you can get rid of this in hours with adequate progesterone for your needs right at that point. So John Lee, the great John Lee, who wrote a great book on progesterone.
He catalyzed my interest in it for sure. He's passed, long past. He's Sebastopol, California, I think it was from.
But he was quite dogmatic that you don't make more than 20 milligrams of progesterone in your body, so you don't need to use anymore.
Yeah, that's it. I think we've made I know you have an appointment in a few minutes, so I think we made a very good case for considering this, and we could go on for another hour, and I might have you back to do that. There's so many other hormones I want to talk about, because you're not just an expert in progesterone, you do the whole deal, so all the hormones, and I'd like to, maybe we'll have you back and talk about testosterone and thyroid, which I think are really important ones too to
Absolutely.
review. But the big one in my book is progesterone. Almost everyone needs it. There's a lot less people who need the others. Many need thyroid. I don't think virtually anyone needs testosterone, because if you address the others, if you take care of the estrogen dominance, your testosterone comes back up.
Right. And so does your thyroid get improved.
Yeah.
So looking at thyroid is secondary for me. I want to see how much people improve by correcting progesterone.
That's the first. That's your first one. Your big gun.
Yes.
The big gun.
It's the big gun. And then revisit thyroid and see if it's still needed.
Okay, that's a good. Thank you for modifying my protocol. That makes a lot of sense. So if someone has done this, they're still having problems, they want to connect with you, how do they do that?
So my website, thewellnessbydesignproject.com, and I've got a lot of videos available at my YouTube site with the same title. Lots of information. And if you want to start learning about what hormone does what, which is absolutely essential in being the observer of your own health and taking charge of it, you can find a lot of resources there.
Okay, great. And for those who follow the site a lot, I knew Carol for a while. I met her many years ago, but I forgot about her. And I talked about the coaching program with my attorney friend, Charlie Brown, Consumer for Dental Choice. And he reminded me about you, and he connected us. So great kudos. I'm so glad, because we have provided people what exactly what I was hoping we would, the information they needed to understand, to really fully appreciate, and so they can be catalyzed and motivated to adopt and integrate this into their program, because almost everyone watching this needs it. So thank you.
Thank you very much. Thanks for the opportunity.
Okay, good. We'll talk soon.
Okay, bye.
Thanks so much for watching. Remember, hit the like and subscribe button so you can get more videos that can help you and your family take control of your health.